clinical documentation and administrivia. You know, the stuff we have to do to satisfy the administrative bureaucratic overlords in order to practice medicine in the United States. Yeah, that kind of stuff. The stuff we do which does not contribute to actual patient care. If we can minimize or eliminate that BS, would it increase time at home, story time with the family, increase practice satisfaction, and possibly decrease burnout, so that it is, which is so pervasive in urology and medicine? In today's discussion, Dr. Aaron Grotas will be sharing how he uses virtual assistants, also known as VAs, to make his life easier. We'll be talking about the nitty-gritty of being more efficient when running a medical practice by using VAs. Now, this is the third time he's been on here, which makes him the most popular guest. If you are interested in seeing prior discussions, click on the card up here if you are watching it on the replay, and that's up here. If you're watching this on the replay on YouTube, and I will leave the links also in the comments. My name is John Lin, your host of the Thriving Urology Practice Facebook group. As always, if you have any questions or comments, I welcome them all during this live stream or on the replay. Welcome, Dr. Grotas, and thank you for kindly sharing your knowledge.
Okay. I've been using HelloRache for about 3 years, and I've had the same virtual assistant. And it's been very useful for me because even though I'm pretty good at typing, I type very efficiently. I have to see a lot of patients during the day to take care of everybody, and to type all the notes and to handle some of the administrative tasks of billing is difficult. So having a virtual assistant is like a second pair of hands, like having a right-hand man, a right-hand woman do some of these administrative mouse clicks for me, administrative tasks that are very helpful in getting throughput done for the day. And I know you use Dragon for dictation, but I never really got into Dragon. And when I heard Kelly talk to you about HelloRache, I said, hey, maybe I'll try this. It's been 3 years, and I've been very happy with it so far.
Let's see. You're probably hearing an echo. Are you hearing your audio in your ears?
Mm-hmm. Should I mute my own audio or something?
No, I'm going to try this. Is that better?
Let's see. Yes, I did not hear my own audio anymore.
All right, sorry about that. All right, so let's go back. Let's go back a little bit here. You are in a practice by yourself, and about 3 years ago, you started using a service called HelloRache.
That's correct. HelloRache is a company based out of Arizona that works with virtual assistants that are based out of the Philippines, primarily, I think exclusively at this point. And even though the company's based out of the United States, all of the people who work for the company are professionals from the Philippines, and some of them as nurses or sort of allied health professionals in the Philippines. And the cost of living, as well as the hourly wage for a worker in the Philippines, is pretty low. So a lot of these employees were able to work as virtual assistants for the US and get a real salary bump and be able to work from home. You know, so there are some disadvantages to the employees because they have to work at night if they want to be live in the US during the day. But besides that, the economic boom for them has been pretty good, especially during the pandemic, where a lot of the Philippines was shut down and they couldn't work. And some of us here in the US didn't have as many employees coming into work, but still needed a lot of tasks to be done. So I know for my practice, this has been very helpful. And in the past year, I transitioned to a new medical record system. I was amazed that my assistant was one of the quickest to catch on to the new system and the most willing to learn a new system as an early adopter, which I know that you like a lot of your employees, that they want to be invested in the practice. And even though this is my farthest distance employee, she is just as bought in as the people who are live and engaged in person with me on a daily basis.
Okay, so you've been using this same assistant, Sasha, if I remember correctly, the same person for 3 years. There was, from our previous discussion, there was a minimum amount of time that you have to engage her or hire her, if you will, so that you can retain this person. How many hours a week is that? What is that minimum requirement?
So I think HelloRache typically was 30 hours a week, but I are at a little bit lower than that, and that's pretty tolerable for her, and I think it works for her. But she ends up doing about 30 hours a week for me right now, and the cost to the practice is under $10 an hour, all in, and she gets a majority of that money, but not all of it, because HelloRache, I pay a U.S. company via credit card, her.
Very good. So it seems like the pricing is still the same as from 3 years ago, because that's what you said 3 years ago when you first started. Sounds like you've been working with the same person in your practice, and she's in the Philippines, but you're in the U.S. Now, let's talk about how you actually implement her. For instance, when you first come into the office, what are the things that you do? I know there are some technology things that you have to do in the background. So how does all that work? Because that's what the audience wants to know.
Okay. So typically, I have a sort of consult room or office where I see all of my new patients in, and I'll bring follow-ups or extensive discussions. So I have a computer, it's a Dell computer in that office. I engage in a Google Meet video conference, which is similar to what we're doing right now with a webcam and with screen sharing, and she shares her screen with me. Sometimes I share my screen with her, especially if I want to demonstrate any new tasks or different things I want her to do. But a lot of times I'm watching as she types notes actively on one screen, and I have access to the medical record on my own screen. So I'll do a prescription while she's typing a history or a physical exam for me. And it helps the day move along a lot quicker, because I can really concentrate on talking to patients and doing procedures and visits, rather than push every word on the keyboard, as well as every mouse click. She can queue up prescriptions. She can queue up for things. And I still implement 95% of the push through of signing off on charts on billing. She doesn't sign off on anything for me. It's taking away any signature functions of the doctor. But just like traditional secretaries used to take shorthand and prepare documents for people, she's really preparing documents which memorialize what happened during a visit, which is kind of nice, because having a scribe in the room for a urologist can be a little invasive to the patient, especially with their pants down and stuff like that. Having someone virtually is probably more helpful. When I do a vasectomy, I have an assistant in the room who's female. When I do certain procedures, I have people in the room, but that's really out of necessity. An extra pair of hands, or I need someone to keep an eye on the patient. If I'm just doing a rectum or doing a testicle exam, it's really not necessarily fair for the patient to have to submit to have somebody stay keyboard in front of them. And if that's how you run your practice and that works for you, that's great. But I found in my practice, and I've been in about 15 years now, that the amount of people in the room when someone has their clothes off, the better. That being said, for any female exam for cisgender females or women, I have a female in the room with me. So I just want to put that caveat out there. I'm not doing solo exam
totally understand
on people of the opposite sex, but in general, for my male patients, I try not to have another person in the room, and most of the time that's their preference. I would never ever say no if somebody requested a chaperone.
Well, I would say in my experience, all of the time, pretty much all of the time, even if it's a spouse of the male patient, they sometimes want that spouse out of the room. Okay, sounds like what you're saying is that you have, in your exam room, you have 2 monitors, and that's where you see patients. And on one screen, maybe the EHR, and the other screen is something else. And you have the ability to see what your VA or virtual assistant is doing in the Philippines as she is documenting on her computer, because it's the same screen that you're seeing on your side. And she's remote, which is good because you don't want a physical person in the exam room. So how does, I guess she's listening to you and watching what you're doing and documenting contemporaneously. Is that what happens?
So sometimes she is a lot of, so I think that you might have misunderstood a little bit. So in my office, my sort of sit down desk office, that's where she hangs out. Her
So she doesn't go into the exam room with
live
you.
with me for, she doesn't come in with every single patient into the exam room for a follow-up. If someone's just there to look at a something and they're a follow-up patient there for a steroid cream or something, I don't need her. I can tell her sort of just afterwards what's going on. But she also helps me in terms of for billing and compliance. There's certain things, if you did a scrotal ultrasound on somebody last week, you can't do another ultrasound on them the following week. So it's very helpful to have someone who can look back at the chart for you and say, you can say, hey, have we done this test on this person recently in the last year? Because as you know, it's fine to do a lot of work for somebody, but for a lot of insurance companies, if you did something in the last 30 days, they're probably not going to pay for it again, unless there's some unique diagnosis or unique reason for it. So one of the things I find most helpful that saves me time is I'll say, hey, we do this today. Is that reasonable? Or does that make sense? And she'll have already prepared and checked what we've done recently for the patient. And even though she doesn't remember the insurance rules for every single insurance, but I have a pretty good handle on that stuff because for a long time I was doing my own medical billing, like you sort of keep an eye on things. So I kind of know most of the rules, and if not, we have a pretty easy reference for that. So I find that's one of the other things. And the other thing that's also helpful is that we'll document a note. Let's say we decide to get a CAT scan and the patient needs prior authorization. So sometimes I'll tell her to go get that prior authorization right away while I go see the next patient. So sometimes the patients can leave the office with their prior authorization number, which is a good customer service benefit. It doesn't slow down the secretary or the office manager in the front from answering the phone. Other people use their VAs to answer the phone, which is another great use of a VA. However, my practice is that the VA is my assistant, not necessarily my secretary's assistant. And I know that some people are having a second VA that will sort of a jack of all trades for any of the front end to be able to answer the phone or spill over a phone call so they don't have to go to a call service or to the voicemail. And in addition, can work on tasks if somebody's out or remote for the day or what have you.
Got it. Makes sense. You're basically, sounds like what you're saying is you're basically seeing the patient sometimes, and then you go back to your office where you have the 2 monitors and you're telling your VA what to do.
Correct. But for the new patient, she's hearing the history authentically from the patient's voice and a conversation with the patient about contemporaneously thinking about. And then let's say if the patient comes in for prostate cancer diagnosis and we're talking treatment and risks and benefits, alternatives, all that stuff documented not in just a template of medical vomit where we say, oh, we talk about, but we actually talk about for this patient's Gleason 6 active surveillance versus CyberKnife versus, and using SpaceOR, and that the patient elected to do SpaceOR fiducial markers or is going to watch it and repeat the PSA. So a lot of this stuff can be documented real time like other businesses. And the thing is that medicine should be like other businesses. And in other businesses, they get real-time transcripts of what's going on, and they create records of every email and what have you, so that they're able to sort of memorialize what's happened. And we should have similar levels of documentation so that there's no question about, oh, did you tell the patient to just watch their prostate cancer? I documented that the patient had treatment options that are just as good, whether the outcomes from surgery or the prostate cancer survival are equal at 10 years or at 15 years. And for a majority of patients, active surveillance is a good option. So there's no question about what I said during the visit.
How do you take her in the exam room for that new patient visit, as you described?
So the patients will come to my office.
Got it.
And so the only part, she will not be there for the physical exam, but as you know, your own practice, when you often, the physical exam, the abnormal findings are what you're really changing in how you document a physical exam. Not necessarily, you're not necessarily writing a complete new composition for every single patient every single time. Correct?
Got it. Makes sense.
Right.
I am trying to understand also, what do you do when you first get into the office? So you go to your office and you fire up both monitors.
Fire up the computer and we log on to a Google Meet session.
Okay, Google Meet. Okay.
Sorry, I use Google Meets. There's Verizon bought another company called Blue Jeans that they were using that I tried for a free trial. I find that Google is the easiest because I'm already familiar with Gmail and how to use it, and I have my own core Gmail account. Microsoft Teams is another very good platform to use, and I currently have Teams in my office now, and I actually dear on our Teams chat, which is a secure HIPAA secure chat that we use as well. However, I haven't been Teams meeting or digital meeting feature. I guess I'll play around with that soon. But I like sticking to what works, and the Google chat works very well, and it is secure. It's HIPAA secure because it's all within one organization.
So are you talking about voice chatting via Google, or are you having to type back and forth with her?
It's a video chat in Google.
Got it.
It resembles what we would look like today. Plus, in this meeting, we could do screen sharing. Same thing.
Got it. And how does she have access? How do you see her doing the typing on your EHR and bringing stuff up when she's in the Philippines and you're in your office?
Oh, so just as if I were to share my screen right now, she would her screen with me, and I can view it on the actual video.
So she's enabling, or you're enabling screen sharing, and then you're allowing her to have control over your screen.
No. She is using her computer. She's accessing the EHR on her computer.
Got it. So she's somehow VPNing.
And she's showing me her screen.
Got it. So she's screen sharing on her end. So there has to be a lot of trust. And Dr. Alex brought up a question. Can you talk about the BAA, Business Associates Agreement, you have in place, which is a huge, huge issue?
Right. So I have a BAA with my virtual assistant. And just yesterday, I talked to the people at HelloRache because in the past, they will not sign a BAA with their clients. So I'm their client. I pay HelloRache, but they will not sign a BAA as a group or as a company because, and their rationale is they don't have a login to my EHR, have access to any of my private information. So their company does not have access for data from my company. And for some people and some organizations, that's sufficient. And for others, they have a problem with that. And on one hand, I've had the same person for over 3 years, and I have a good amount of trust with this person, and I feel very, very comfortable at this point. It did take a leap of faith at the beginning. However, virtual assistants in other countries are very popular now for tax businesses, law businesses, and other very sensitive information. So it's not that HelloRache is the only company doing this overseas. There are lots of them. And if you outsource your billing, there are people overseas doing your, whether you know it or not. One of my friends down the street, he's a pharmacist, or he runs a pharmacy. They have 10 employees in India and other places doing a lot of the behind work, because they can get this cost down below US minimum wage, or below your state's minimum wage, which saves a decent amount of money if you have skilled employees. However, I think we were chatting about this yesterday. I think if, let's say, God forbid, there were a legal problem with data or financial information of a patient, it would be rather difficult for me to get somebody involved in the Philippines to try to punish somebody or extract some sort of blame someone in a foreign country. I really don't have any legal background of how I would do that. While I guess in the US or in New York I am, if God forbid one of my employees did violate some trust in sort of someone's information, we could take them to court and get back the money or something like that, or at least punish them. However, HelloRache did assure have very strict privacy laws in the Philippines, and that any violation of somebody's trust in the US would be enforced in the Philippines and would result in fines and or jail time. So I think, and that's part of, they do very good HIPAA training through HelloRache, and they did show me all their modules and make that stuff available to me, probably better than I do for my employees, or some of us do for our employees, even though I do train my employees and try to keep my medical information as possible. But that was one of the things that reassured me about using this company, is that they actually do vet their employees. And I did have a chance to interview my employee before I hired her.
Well, just to be clear, HelloRache does run background checks like I do on my employees. They do run background checks on all the VAs who they hire. In addition, their VAs have to go through the equivalent of a HIPAA compliance training, and they have to demonstrate satisfactory proficiency in those modules before they will be hired. The Philippines has, I think it's called the Data Protection Act of 2012, which is to which you referred, regarding how the people who interact with protected health information will have to behave, and how they interact with that information, and how they manage that information. That hurdle, that person being in the Philippines and not having a US-based type of a person is sometimes a no-no for certain healthcare entities in the United States. And I think Dr. Casperson, from whom you learned about, well, one of the people you spoke with before you started using HelloRache 3 years ago, I think she stopped using VAs through HelloRache because I think her EHR vendor, or it's Epic.
Right.
For some reason, they don't allow her to have the VA access the EHR in the way you described and the way she was using it. So she's no longer using a VA because of that. So that is something to consider for those people who are listening and watching before you implement electronic VAs and giving them access to EHRs.
Right. So I work part-time for Mount Sinai Hospital in Manhattan, and I don't have Shasha with me when I'm at hospital, and part of the reason is because we're on Epic there. And Epic is a very efficient EHR. While it does resemble DOS programming in a lot of ways, the shortcuts are very weird and very sort of hard to get used to, but you can very efficiently see patients with Epic without a scribe. And I think that it allows some customization. And what was frustrating for me when our hospital went on Epic there is that they redo everything for the practice.
So I'm sorry, your audio skipped. They redo what?
I kept asking, what is the template that you use for the other urology practices? And they're like, no, we do this for you.
They customize it.
But it's almost very inefficient that way. And I found this to be I guess this is a problem with our industry in general in medicine. We don't take the knowledge of everybody's knowledge and aggregate it to help everybody.
And that's why the Thriving Urology Practice Facebook group exists. It's free, and we freely share information so that we can all benefit. I too am frustrated about having to reinvent the wheel every single time that we do something. And what you described is exactly the dogma that is pervasive in medicine. If you want to do something, you have to invent it. You have to create all the protocols. I think that's just so stupid.
Right. And I think that this is why there's so much burnout in medicine, because we're constantly reinventing the wheel. And I think that this virtual assistant has allowed me to have less work outside of the practice. When I leave the office for the day, it's not weighing on me that I have charts to close or I haven't sent my bills. Yesterday I was running around and I did a procedure in the office a while, and I didn't see a ton of patients, but I saw some patients, and within a few minutes I was able to catch up because I had a virtual assistant and my staff. And by the time I got home, I didn't have to worry about my office as much anymore, which is a big thing for doctors in this modern era, because we have so many stresses, keep cutting our reimbursements for things. So to think that I'm going to work hard all day and then come home and not be able to hang out with my kids or go out for dinner or go for a swim or whatever I want to do, would kind of stink, because we're already working a lot and we're already spending a lot of our energy to help people.
Sounds like what you're saying is that having a virtual assistant allows you to free up some of the time. Basically, you're buying back time so that you don't have to deal with the administrivia that we have to deal with to satisfy the bureaucratic overlords.
I think that's pretty right.
Right.
Yeah, and for example, so Shasha does some billing functions, and it'll go ahead and we'll get a rack of some denials, or the ICD10 codes were wrong and stuff like that. Because she contemporaneously works with me all the time, she knows more about this stuff than some of my others, because she's constantly talking to me about this stuff, and she knows the NDC codes for the drugs we use that are unlisted without me having to tell her. So she could look at a sheet of denials and be able to plow through it at a much more efficient rate than someone who's just using this as a task that has no familiarity with the subject.
It sounds okay. So tell me more about the ICD10 issue.
Right. So so for example, a new EHR system, and it used to be that I would get the alerts myself and get a problem list of certain codes that got rejected, solve them. And this, they kind of create a work list, and some things are not. We might have put the NDC number in the wrong place or what have you, but is that it's not like I have to type back to someone and tell them all the codes, because she has been with me for the last 3 years, and these are not new things. So I don't have to reinvent the education to a new staff member on how to do things because she's been doing this stuff already with me.
Yeah, it sounds like what you're saying is that based on her previous experience with you, she knows some of the appropriate codes that are supposed to be used. I was thinking that she was the person picking the codes.
No, she would pick based on the protocols that I've already implemented for her. So she knows that if we use Lupron, like what the NDC number is for the Lupron, like that, not because she's deciding that oh, this is medically appropriate. Knows that it's for prostate cancer because that's the sort of rules that I've implemented, and I kind of keep everything very black and white. And then if there are exceptions, highlight the exceptions to the rules.
So basically, she's following protocols or workflows that you've set up.
Correct.
Okay, sounds reasonable. Not only does she perform the administrative documentation functions in your practice, she also helps you submit the claims and work the claims on the back end, from what I'm hearing.
Correct.
Okay, interesting. So you're still doing billing in-house?
No, so we have a service that does the billing, but they kick back the rejections back to us. So it's interesting. You think that they would just deal with it?
Well, hang on. That's convenient because these billing services usually charge you a percentage of what they collect. So whatever's easy to collect, they take, but then all the headaches go back to you. How does that work?
So it's not they don't get a strict percentage. So it's
okay.
But you are correct. This is a new system for me. I joined an MSO that has better rates.
Got it.
That's part of it. So this has all been very educational for me. And part of it is having to change EHRs, which was not that big of a deal for me, but it's very frustrating when you can't tweak things just the way you want them. So it's not easy. However, right, and for example, one thing is just the other day they said, oh, by the way, how are we going to deal with these claims that are almost expired? And I was like, what are you talking about? This is the first time hearing about this. I'm like, oh yeah, we put the box of one of your employees, and I'm like, I'm out. So I got upset, and the irony is, if they had been in Shasha's inbox or my inbox, they would have right away. But I was only made aware of them recently. So we fixed it all in 4 hours. But you can't, even if you outsource everything, it doesn't mean you can close your eyes and close your ears and just hope the money comes in. Because no matter what happens, and they send you a report, I don't know if you've ever seen some of these accounts receivable and aging reports, but if you're not used to seeing this stuff, it's kind of garbage. And it's kind of, I wanted to know my batting average. Okay, 99% of the claims went through, no problem, first pass. I want to know, okay, after we tweak things, and in 30 days, 98% of claims were. And if someone can't tell you that kind of information, that granular data, then they're not really on top of your billing. What do you think about that?
No, I think you have, whichever service, however you do this, you have to be looking at your numbers. And a lot of solo, you're kind of unique because I have a lot of practices that will tell me, well, we're solo practice, or we're just solo practice with a couple of APPs, advanced practice providers. We don't need to keep track of RVUs. We don't need to keep track of numbers. Well, okay, fine. If whatever you don't measure, you can't improve on. You can't tell what is going on. So what you're doing, I think, is I won't say the right way, because there's no one right way. There are many ways to skin this cat.
Sure.
I think it's the efficient way if you want to iteratively improve how you do things. And one of the, as I've said this many times, one of the dogmas is in medicine is, well, we've always done it this way and it's worked fine and we're going to continue doing it this way. And it sounds like you and I are of the same mindset, that what works today may not work tomorrow. Let's figure that out first before somebody else puts us out of business.
Right. For example, like right now, I don't have a physician assistant or a nurse practitioner in my office, but let's say I get one tomorrow and they want, or they propose a bonus structure based on RVUs or it'd be very hard to bonus them based on receivables because it's going to be hard to tease out which are my work and which are their work. But work RVUs are very good at differentiating that and saying, oh, right, because if they see somebody, follow up, that's their work RVUs. But it's very hard to tease that stuff out when you're saying, okay, well, patient YZ was seen and there was $500 came into the practice, right?
Yeah.
It's so simple because you as John Lemon MD or Sunrise Urology or my practice, $500, some of that at the rent and the electricity and this and that, and you can't necessarily bonus someone based on that $500.
Yep. And I'm going to go through some of the questions that are coming through.
Please.
Kyle asks, has anyone used HelloRache or something similar for more administrative tasks or clinic coordination? I think you do that.
Yeah, and for example, this MSO that I'm part of now, they had 3 people doing the billing for a couple of practices. They punted all of that to a HelloRache virtual assistant. So they were able to eliminate 3 full-time equivalents and pay one virtual assistant. So they basically paid 1/9 the amount of money to do the job of 3.
That may be good or bad, depending on your perspective, right? If you're the employee.
Well, I guess if you're watching in Europe, I apologize for introducing this as an option. However, there is nothing wrong, and I guess this is all part of the discussion about artificial intelligence. We can use ChatGPT how to talk to patients or how to get back to patients, but really, it's about our ability as the doctor or provider to be able to interpret and to ask the right questions, to come up with the right things to talk about and implement things. So I think as someone who's a certified coder or a biller, the key is to figure out, well, hey, these are tasks that are automated. These are things I can assign to someone else who might make less money per hour than I do, but be more efficient and be able to do things potentially, from the nice thing also about the Philippines is they could be Nighthawks for you. You could leave a set of tasks at the end of the day. They could work during the day over there, and by the next morning, you have a full day of production done for you.
And so speaking of
chart prep, clinic templates, or after hours phone calls to people reminding them to come into the office. I don't know about this, but I think that texting people to remind them to come to the office, calling them, showing people that you're engaged in their care, even if it's not you personally, is a real key to keeping your practice going well.
And I will tell you, that is one of the secrets of my success, is that I have amazing, very engaged medical assistants who do that for me in the office. This is a great segue to the next question. Somebody asked, can the VA call pharmacies or send the prescriptions over electronically?
So that is a great question. And I think that a lot of that has to do with how your records are set up, how your EHR is set up, as well as how your protocols are for what's allowed where you are. My old EHR, I did not have my medical assistant put in any prescriptions at all, not even queue them up for me. I would do them all myself. The way it works with the new, we use CureMD now, which I don't necessarily recommend to anybody. It is a little cumbersome to use, but after 3 months, I am getting the hang of it, and it's okay. And I'm happy to answer questions about that, or people can DM me about CureMD if they're thinking of using it. But my virtual assistant is allowed under her login to put in and queue it up for me to sign. And I believe I'm allowed to let her put the prescription in for me. but I don't know if that's really kosher, if that's technically allowed. And I really wouldn't want, she is not a nurse who could call in prescriptions. So I don't keep that function for her, and I don't ask her to do that.
Very good. So I'm going to clarify something here. She has the ability to order the prescription in the EHR and bring it down on a drop-down list, but she does not have actual prescriptive authority to send the prescription to the pharmacy. I just want to make that clear for the listening and the watching audience. All right. So somebody else, Gail asks, what about administrative duties such as answering the phones and making appointments for the office? And Chanel says, my VAs do all of that.
So I do not have my VA do that, but there are definitely within this MSO that I'm part of, there are VA take over the phones via the VoIP phone systems. It's very easy to get a phone for them there that they can literally pick up the phone as if they're in your office. One about my assistant is she really has almost no accent. So I know you talk about coming to this generation and being sort of very careful about your speech. And I'm picky in my VA that I would want someone that I would be able to understand, that I would be able to understand her and she could understand me, as well as, you know, she will call insurance companies for me. And I never wanted anyone to get the impression that I'm using someone for overseas that would compromise or delay things and cause added confusion for anybody. But certainly that is a consideration when having people answer the phones, and especially in different parts of the country, people may be less accepting if someone has an accent that's different than that region of the country.
Well, I think in medicine, just as in life in general, you want to decrease the friction for someone to consume your information. So when you're communicating with somebody, you want to use the native tongue. And someone who has an accent, you're creating more work for the listener to understand the message that you're trying to get across, which brings me to the next point. If you don't mind staying on afterwards, Aaron, I want to work out this audio problem that I'm hearing on your end throughout this entire live stream. I think the audience is hearing it too, but they are very gracious and they're tolerating it. All right, so perfect segue. Danielle asked, are there barriers with English? And I think you addressed that in the first interview that we did 3 years ago. You picked Sasha because of her proficiency with the English language, something that I'm very conscious of because, as you mentioned, I'm a first-generation immigrant to the United States, came to the States when I was 11 years old, always and still am very very self-conscious about how I sound and how I speak. And having that smooth, almost like a completely transparent type of a setup where Sasha is an extension of your practice, and when she engages with your patients, people would be none the wiser regarding, hey, is she actually in the States versus if she's overseas, because she has minimal to no accent. Am I correct?
That's absolutely correct. That's really the key, but that definitely wasn't the rule for all of the people that I interviewed over Zoom or one of these other medias. And interestingly, some others were RNs in the Philippines and might have been more qualified to help me in my practice from the beginning, particularly with patients because of their medical knowledge. But it's almost like you pick their weather person based on their presentation, not necessarily their meteorologic background. People come to the office for me. They come for the knowledge that the urologists and the urology providers bring. The other people would be a reflection of the customer service and the care, and they have to have big hearts and be able to be big communicators. But they don't necessarily, I'm not necessarily looking for the people who are performing secretarial functions or medical assistant functions to be the doctor. I want everybody to be the best they can be, but I do expect people to grow with the practice. but not everybody will be a doctor, and they didn't go to medical school. So we shouldn't hold them to that standard. We should hold them to the standard of being good communicators, being compassionate and good people. And I think that's the key. And that's what you really want to look for when you're looking for in-person or virtual employees, people you can understand, you can communicate with, and are responsible.
I completely agree. We tend to hire for attitude than aptitude. We can pretty much train anybody to do the things that we do in the office, and answering phones and communicating with the patients, and also the basic disease processes about the procedures that we do, also the conditions that we treat. So somebody else asked, Gail asked, how many interviews did you have to do to find the right VA?
So it only took about 3 or 4.
Okay, sounds good. And from what I'm hearing you say is that you hired basically because she sounds most like a native speaker, and you didn't necessarily hire the highest credentialed VA from the Philippines.
So she had a background. She worked in a radiology office in the Philippines, I believe, but she did not have formal medical training or something like that. So she was in a medical related field, but she wasn't a medical professional per se.
Sounds very good. And this is a question that Todd, Dr. Learfield asked, has anyone discussed these with their healthcare lawyers? Mine, he mentioned the person's name, said absolutely not, with some colorful language. How did those who use these VAs get their attorneys to okay them? That's a valid question.
You know, I think that the fact that there is a BAA in place, and that for me, that it is a U.S. company that we're using. You know, my current MSO is, they have about 50 or 60 doctors. They have a big time healthcare law firm that's on retainer that handles a lot of different things. And this is one of those that they have sort of gone through and been okay with, and they're perfectly comfortable within the statutes of liability in New York State. And New York State is a difficult state for healthcare regulation. We can't own labs here. We can't own pharmacies here. It's a little different than other parts of the country. One benefit, I think the cost of living adjustments are a little better up here for reimbursement, so that's good. But it is really expensive to live and work here and pay people. So I think that I can't tell you. When it comes to legal advice, you should use people you trust. If they say this is a no-go, then I think you should listen to them. However, this is becoming more and more popular, and I believe there is a urologist in our group who has his own virtual assistant company, if I'm mistaken. And I would love to hear the legal aspects from the other side, because health is probably not going to talk to us about being sued or what that's about. This guy, I'm sure, has thought about this and done the due diligence of how to protect himself and practice from this from the legal protections of being part of a virtual assistant company.
I think she started the company, so I'm going to have to get her on and maybe interview her. Anything else we haven't covered, Aaron?
You know, John, I really enjoyed talking to you, and I'm sure we could talk for hours about this and many other topics. But I think I'm pretty good. I am always, whereas I may not be able to get back to people the same day, but you can feel free to message me either through the regular chat or some of these other chats that John's created that I get lots of notifications about now. This new Facebook Messenger chat group is interesting. I haven't really played around with it too much yet, but it's cool. Or you can message me directly through my account, and I'm happy to answer questions that people have or other aspects of urology. My older brother's also a urologist who's part of our group, and my is semi-retired, and he's also a urologist. So urology is really in my blood, and I really being a urologist, I enjoy sort of being a part-time academic and doing some other stuff. I do some transgender work and help with the transgender community, which is very interesting. And I know is a little bit controversial, but I think that there's definitely a role, and urologists need to be involved. And whether or not you're politically interested in this, or you're politically, whatever your political views are, I think as urologists, people who have genitourinary reconstruction are going to need care. And we all need to have some competency to be able to help, even if it's not something we're passionate about. That we don't want to do any gender reassignment surgery, hormones to patients. Urologists, just like with genitourinary syndrome of menopause, which I've learned a lot about from great people, from great women in this group. I think that knowing about these, even if you're not the primary deliverer of care, is very important, because I think, especially with genitourinary syndrome, I think that I've helped a lot of women that I wouldn't have even thought about helping, and really changed their lives for the better, which is really fun, great. And I think that it's a real positive of being parts of groups like this and communities like this.
I completely agree with you. Dr. Rachel Rubin and Dr. Kelly Casperson are doing a great job in educating all of us. And as a matter of fact, I think Dr. Rubin is presenting in St. Louis this weekend at the ISHWISH meeting. I can't remember the name, International Society for the Women's Health and Sexual Medicine or something like that.
That's pretty close. Yeah.
I actually crashed one of their meetings when they held it here in Scottsdale, and I met a lot of great people and learned a lot of good information. All right, Aaron, stay on and we'll chat offline. We can figure out the audio issue. And thank you so much for coming on again for the third time.
Thank you.
All right, for those of you who have stuck with us throughout all the technical difficulties, thank you so much. As always, if you have any questions or comments, please leave them below. And I'm sure Dr. Grotas and I would try our best to answer them for you. And as always, I really appreciate the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.